graduate of the Faculty of Medicine, University of Colombo, and obtained his MD Medicine from the PGM Colombo. He also has MRCP UK, MRCP London, MRCP in Acute Medicine, and MSc in Medical Toxicology. He also is a fellow of the Ceylon College of Physicians, Royal College of Physicians, and I think Japanese Cardiovascular Society. He is a consultant cardiologist and a professor in cardiology, attached presently to Faculty of Medicine and Mental Health at University of Moratuwa. He graduated with second class upper division from the Faculty of Medicine, University of Colombo in 2005, and he was awarded the Dr. Nanda Amarasekara Prize for the best performance at the MD Medicine examination held in 2011. He underwent postgraduate training in general imaging and interventional cardiology at the Institute of Cardiology, NHSL, and subsequently as a specialty registrar in cardiology at Shrewsbury and Telford NHS Trust and Royal Stoke University Hospital, UK. He was board certified as a specialist in cardiology in 2015 and has also received level 2 cardiac CT accreditation from the British Cardiovascular Imaging Society in 2017. He has earlier worked as a honorary consultant at Teaching Hospital Anuradhapura when he was attached to the Rajarata Medical Faculty. He has been a council member of many societies, including Sri Lanka Hypertension Society and the Asian Heart Society Prevention Council. He actively contributes to the national guideline development and undergraduate and postgraduate training. His research interests include cardiovascular disease, cardiotoxicology, cardiac disease in pregnancy, tropical diseases, and medical education. He has authored over 29 peer-reviewed journal publications, contributed to 50 reference conference abstracts, and delivered presentation at major national and international forums. He is also a reviewer for leading journals and has served and also serves on the Sri Lanka Heart Journal editorial board. Over to you, Dr. Niroshan.
Thank you, sir. Can all of you hear me?
Yes, we can hear you well.
Right. Okay. Thank you very much again. So in next 1 hour or so, we will be looking at some aspects of the infective endocarditis. Although some slides are maybe crowded, but I'll highlight the important areas for this course. Can you see moving slides? Can you see the second slide? Right. Okay, good. So during this, I wanted to tell something about epidemiology, clinical manifestations, and diagnostic criteria, and then management and prevention. So this lecture is based on these guidelines. Actually, last guideline, detailed guideline is 2023 ESC guideline, European Society of Cardiology guideline for infective endocarditis. So also I took some details from the AHA scientific statement and American Heart Association statements and British Society of Antimicrobial Chemotherapy statements, and also modified Duke criteria document. So infective endocarditis in valves, atrial and ventricular endocardium, and large intrathoracic vessels and intracardiac foreign bodies. This is a lengthy definition. Simply, as if it is infective endocarditis, it's an inflammation of endocardial surface. As it is infective, it is by bacteria or fungi, which leads to formation of vegetations. Usually these vegetations happens at the heart valves. We are going to discuss that. So today we are going to discuss infective endocarditis. As you remember in your medical student days, there is something called non-infective endocarditis. It's a very rare condition which can happen with tiny sterile lesions, endocardial lesions with platelet and fibrin. These are associated with malignancies and connective tissue disorders. For example, if you have some malignancy and associated with this kind of thing, we might tell it's a marantic endocarditis. If it is associated with SLE, we might say it's a Liebman-Sack endocarditis. These are non-infective endocarditis. Today, my topic is on infective endocarditis. Right. So, if you just go through the pathogenesis, more than 50% of cases underlying valve abnormality. It may be acquired or congenital. What basically needs is some turbulence blood flow, and which can, with some transient, there may be a colonization on the endothelium and this endothelial surface, and this infection can set in. But does not need always this turbulence and all these things. Even Norman valve can get this infective endocarditis if you have a very powerful organisms like virulent organisms like Staph aureus, and sometimes it happens in the intravenous drug users. So with variable portal of entry, it may be mouth, it may be skin or intravenous lines, or it may be from gastrointestinal tract. This bacteria enters into the body, and these can adhere to the endothelium, and it can damage, or if it is already damaged or turbulent endothelium, they can stay there and proliferate with some inflammation with neutrophil and macrophage. Then this specific form of vegetation will acquire. But problem comes with these complications. Before that, I'll just have one slide with what is the epidemiology. So it is commoner in males, but the latter part of the age, females have higher proportion. In high-income countries, it is mostly due to staphylococci. It may be related to the degenerative valvulopathies and prosthetic valves and implanted devices. But in low-income countries, mostly it is streptococci, and it is associated with rheumatic heart disease most of the time. In Sri Lanka also, we see mostly this streptococcal predominant pattern. So infective endocarditis can be classified in different ways. It may be due to etiology, bacterial endocarditis, fungal endocarditis, likewise. Or if you identify the organism, you can name by organism, streptococci endocarditis, staphylococcus endocarditis. Or disease cause. If you have acute cause within 1 month from the onset of symptoms, you can say acute infective endocarditis. But if it is more than 1 month, you might name it as subacute or chronic bacterial endocarditis or fungal endocarditis. Usually it is bacterial. So according to the valve involvement, so you can classify native valve endocarditis or prosthetic valve endocarditis. In Sri Lanka, we mostly see native valve endocarditis, and also side of affection. So if it is involved in the right-sided valves like tricuspid valve, we say it's a right-sided endocarditis. Or if it is from the left-sided valve like mitral or aortic valve, we can say left-sided endocarditis. So we have, as you already know those things, you can classify them different way. Importantly, now we are going to learn something about endocarditis. So again, the management, and at the end of the day, it is by a teamwork. So it ideally at least complicated cases of infective endocarditis should be managed at specific centers, infective endocarditis centers. But otherwise, in our setting, sometimes uncomplicated patients can be managed at district general level, or somewhere you can have cardiologist and physician and some other specialties. So ideally, you need cardiologists, cardiac imaging experts, surgeons, cardiac surgeons, and microbiologists. And sometimes as adjunct specialties, you need radiologist, neurologist, nephrologist, critical care consultants, and anesthesiologist. And likewise, you need a lot of things, and then paramedical staff, including specialized nurses, who can treat these patients, help treating these patients. So it's a teamwork again. So now I'm going to discuss how do we diagnose infective endocarditis, clinical, echocardiographic, and other criteria. During the same area, I'll just explain some of the pathophysiological mechanism. Right. So clinical manifestations, are influenced by multiple contributing factors. It depends on the virulence of the organism and persistence of the bacteria. For example, Staph aureus infective endocarditis are very virulent, and it can affect and it can cause very dramatic cause and has poor prognosis. And extent of local tissue destruction of the involved valves and hemodynamics equally. If that particular infected endocarditis affect the valves, the clinical manifestation is different, and it can cause even hemodynamic compromise. And if it involves in the perivascular extension of the infection, again features are slightly different. And if it embolizes to other organ, so you can see all these things. For example, if you have a tricuspid valve endocarditis, these things embolize into the lung, which can cause lung abscess, pulmonary complications. But on the contrary to the right side endocarditis, this can be embolized into systemic circulation. It may cause stroke or other complications, which we are going to discuss. Or else consequent circulating immunocomplexes, which can also give some other clinical manifestation. There will be another slides to explain some of these things. Right. So, if you simply think about clinical manifestation, majority presents with fever, almost 95%. But many have, in addition to fever, some constitutional symptoms, non-specific constitutional symptoms such as chills, sweats, maybe cough, headache, malaise, nausea, myalgia, and arthralgia. But they are less common and more maybe present in the even subacute cases. But heart murmurs is a very important and very common finding. So you have to look for this. You know, even in medical studies, fever and murmur, first differential diagnosis infective endocarditis. So they can present with petechiae, splenomegaly, and embolic complications. So this is a very detailed slide, but I'll just go through some of these things, and some of these things will be repeated later. For example, infective endocarditis can affect many systems. It can manifest in skin, in genial lesions, ocular nodes, petechiae, even sphincter hemorrhages, likewise. So, lung, it can cause septic emboli and pneumonia, empyema. CNS, it can cause stroke. We'll discuss that also. And meningitis and encephalitis and maybe slug spot as just a clinical manifestation. Spleen, it can cause splenomegaly, abscess formation, and renal splenic infarct. Musculoskeletal system, it can cause arthritis, osteomyelitis, and discitis, epidural abscess, and psoas abscess. And for heart itself, valve vegetation can cause hemodynamic effect, acute mitral regurgitation, aortic regurgitation. Likewise, they can go into sudden pulmonary edema and cardiac compromise. And vegetation can embolize into systemic or pulmonary circulation depending on the site. And it can cause myocardial abscess and periannual extension of the infection, which can cause fistulae and shunt. And sometimes it can itself cause myopericarditis. So vascular complication, these organisms can damage the vessel wall, can cause myocardic aneurysms, can be ruptured, maybe inside the brain, or maybe unruptured. Then it might rupture in some other day, later time. Your infected endocarditis might be healed, but after a few months, suddenly patient comes with a stroke. Renal can act as abscess, infarct, or glomerulonephritis. I have few slides to show those things, but I'll go through quickly in that position. So, should you suspect infective endocarditis? Can you hear me?
Yes, but on and off we are having some
Because
interruptions,
it
but
is
we can hear.
told that connection is unstable, right? So, especially you have to think about phenotype, because if the patient, especially if the patient is an valvular congenital
We are
heart
having
disease,
interruption
there
erosion.
are predisposing conditions. We'll discuss that. And internet connection. Can you hear me now?
Yes, much better.
Better, right? Okay, we'll see. Thank you, sir. Right. I think you can see the screen again now.
Yes, but we can go to the presentation mode.
Is it not?
Yes, now it's okay. Yes.
Sorry. Right. Okay. Right. So, especially this predisposition now, if your patient is a patient having IV drug use history or maybe suspected of that, indwelling catheter, dental infection, if patient is immunocompromised state, if this patient presents with unexplained fever or new valvular regurgitation, you can hear new murmur, you have to suspect this. And as I mentioned, there are a lot of clinical symptoms and signs. If you find them and if you suspect them, you can find more detail of that. So you can see symptoms. Just I'll quickly go through this. You can see fever is almost ubiquitous, 95%, up to 95% you can see, but other signs are less. And even weight loss and other things are systemic signs are maybe 1/3 of patients are having. If you go to the signs, again, fever can be a sign. Murmur is also for present in murmur or new murmur is seen in significant number of patients. But you can see our medical standards peripheral stigmata of infective endocarditis are rare, especially current days with antibiotics. Sphincter hemorrhages, genuine lesions, osseous nodes, retinal lesions or hot spots, they are rare. Right. So I'll just use few organ systems. So because some of these are important in the echo assessment, because some of you already do echoes as MOs as medical officers working in the cardiac critical care. So vegetations are usually located along the line of the closure of the valve leaflet, usually atrial surface of the AV valves or ventricular surface of the semilunar valves. In other words, if you have aortic or pulmonary in endocarditis, you can see the vegetation should be in the ventricular side. And atrial side, you can see these things in the mitral or tricuspid valve endocarditis. And also, acute endocarditis, vegetations are usually larger and more friable. And but in subacute or chronic cases, vegetations can be very small and can be missed. So myocardial abscesses are common with acute staphylococcal infection. So this is a summary slide which I'm going to discuss in next few things. So if you get a patient with some of these suspicious signs or symptoms, how do we evaluate? This is just a brief summary, but there are more elaboration later. So definitely you have to get the blood cultures. I'll tell some more details about that. You have to take 2 to 3 sets, ideally 6 hours apart. But guidelines, this latest guideline does not make much fuss about that, but you have to see the rationale. But definitely these should be taken before initiation of antibiotics, all 3 sets. So definitely transthoracic echocardiogram is very important, and there are some indication for transesophageal echocardiogram. For example, if you can't diagnose that transthoracic echo, you have to go for transesophageal echo. And also, if a complication suspected or if you are thinking of some intracardiac lead is present and if it is infected, you have to go for transesophageal echo. And especially if there are virulent organisms or prosthesis involved, you have to go for transesophageal echo. There is a slide to show that. And new guideline has some other diagnostic things like cardiac CT. So it will delineate paravalvular involvement of surgical, and it can help for surgical planning for the cardiothoracic surgeon in the complicated case. So if you go for echocardiography, so it is a must if you suspect infective endocarditis. blood culture and echocardiogram, both are musts. So it will be useful for diagnosis and then assessment of severity of the disease and to predict prognosis and predict embolic risk. For example, if you see large friable like vegetation, you know there's a high risk of embolization, especially for strokes. And you can identify complications, paravalvular abscess, and all these things. And it is good for follow-up, and it will help for management options. So I'll give a slide for the time's interest, right? So as I mentioned, if you have clinical suspicion of infective endocarditis, you have to do the transthoracic echo. Where we'll do TOE. I mentioned some of the things. So if you are having a prosthetic valve, patient is prosthetic valve or intracardiac device, TOE is a must. And your transthoracic echo didn't give answer, and you are still suspicious of infective endocarditis, TOE is a must. And also nowadays, even positive transthoracic echo guideline recommends, if possible, do TOE because it will be helpful for baseline parameters and then follow up. And more importantly, more commonly, you will remember we do transesophageal echo in our day-to-day practice when we don't have positive diagnosis from the transthoracic echo. So if you have clinical suspicion is high clinical suspicion, we go for TOE. If even after the TOE, it may be even negative. But if you are really suspicious that you can't find any other alternative diagnosis, you can repeat transthoracic echo and transesophageal echo after 5 to 7 days, depending on the facilities. But if your transthoracic echo negative and your clinical suspicion is low, you can stop without going to transesophageal echo. So what are the echo features which are suggestive of infected endocarditis? Number one classic thing is vegetation. That is an infected mass attached to an endocardial surface and implanted intracardiac material. You can see aortic valve vegetations. Here mitral valve vegetations. You can this mobile and this tricuspid valve vegetations, which is very larger here. This is actually a mitral valve prosthesis with and you can see some mobile area, mobile vegetations on the annulus. Here also tricuspid valve large vegetation. This is actually pacemaker. It's a transesophageal 90. This is a TOE view. Vegetation on the pacemaker lead. Apart from vegetation, you can find some other complications like abscesses and pseudoaneurysms, perforation, fistulae. I'll show an example of fistulae. You can see there are a lot of videos in the various websites. You can see there's a fistula in between. This is left atrium. This is left ventricle. You can see this anterior mitral valve leaflet is not healthy. So there's a communication. There's some perforation like thing, and it is communicated through that left atrium and left ventricle. So you can have valve aneurysms. So there are a lot of features and complications you can find from the echocardiogram, and you can confirm with the surgery or necropsy. And also, if it is a prosthetic valve, you can see adhesions of the prosthetic valve, because it's a very terrific complication which most of the time needs surgery. But all these vegetation looking like things are not vegetations, you know. It can be fibrosis or calcification, maybe some partial caudal rupture, which happens sometimes back. Or in the mitral valve, it may be just myxomatous degeneration of the mitral valve rather than mitral valve vegetation. It may be some imaging, because of your angle, you might see something else as vegetations and some strands with various names. And it could be even old vegetation, very difficult to identify or differentiate. I think sir also will agree, old vegetation from new vegetations. Always you have to get the clinical picture, and it may be even cardiac tumors. So what happens in the kidney? There are three pathological processes. It can cause septic abscess or infarction or glomerulonephritis in the kidney. You can see multiple areas of infarction. The vascular complications, that is very important because you can see these patients. So mycotic aneurysms are aneurysmal dilatation of the artery and usually present as a case of acute infective endocarditis. But as I mentioned earlier, these mycotic aneurysms can happen in the arteries and stay without much prominent, and later they can rupture. People thinks, scientists thinks it is due to direct invasion of the arterial wall with microabscess formation. And in addition to that, there may be some embolic occlusion of the vasa vasorum. Likewise, there are several mechanisms. But what you have to know is infective endocarditis can affect arterial wall and make some weakness, and this can rupture, right? So mycotic aneurysms tend to occur at arterial bifurcation sites and more commonly find at the cerebral circulation. That's why they are getting strokes. So you can see, this is the cerebral angiogram. You can see mycotic aneurysm. So apart from mycotic aneurysm, there's another way of getting the stroke, that is from cerebral emboli. From directly, your vegetation is embolized. So usually middle cerebral artery territory commonly affected. So it can cause cerebral infarction, arteritis, even abscess, and it can cause mycotic aneurysm at that particular site, and intercerebral or subarachnoid hemorrhages, encephalomalacia, cerebritis, and meningitis, all those things. Roth spots, you know, it's a retinal manifestation, and you can see that. But remember, Roth spots are not pathognomonic of infective endocarditis. It can happen with some other conditions like vasculitis and vasculitis such as SLE, right? So, but you should be very fortunate to find this. But still, once you have a patient, you have to examine the patient's fundi to see this. It may be 10%, less than 10% current days, as I mentioned earlier. So it's an interesting finding, but it's a rare finding. So splenomegaly is common, and splenic infarcts can happen, usually clinically silent, but very rarely it can manifest. Splenic abscess can happen, but then it is the problem. The patient might be in the surgical ward or maybe in the medical ward itself with left upper hypochondrial pain and fever and leukocytosis. If you see splenic abscess, you have to think one of the possible sources from infective endocarditis. Right. Lung can be affected from right-sided infective endocarditis from pulmonary embolism with or without infarction. It can additionally cause acute pneumonia, pleural effusions, and empyema. Skin involvement, you can see palatal petechiae, conjunctival petechiae. It may be due to septic emboli itself or some immunocomplex reaction. Our medical student is Osler's nodes, which are painful and red, or maybe in our color, maybe brownish nodular lesions at the pads of the fingers and toes. You have to check fingers and toes. This is because of immune complex deposition and focal vasculitis. Genital lesions are painless hemorrhagic macules, and sometimes it might cause uh, because due to embolizations. Sphincter hemorrhages are also painless, dark red linear lesions and the proximal nape bit and make coleus. So sometimes it is very difficult to identify sphincter hemorrhages. Sphincter hemorrhages is also not pathognomonic of infective endocarditis. It can happen due to some other reasons. So our embolic sphincter hemorrhages, which happens in the infective endocarditis, usually at the proximal side, but it can happen even distal side. But if you see the distal side, distal sphincter hemorrhages, it may be even due to trauma rather than infective endocarditis. But you can't exclude infective endocarditis if you see a distal sphincter hemorrhage. So what are the organisms? I'll just show this slide and I'll give you a more simplified slide. So you can see a lot of organisms can cause, especially many of the streptococci, except your streptococcal pneumonia and streptococcal pyogens. All the streptococci can cause infective endocarditis. And staphylococcus, enterococcus, and some other organisms. And there is something called Hackett group. I'll show them. And if you have a prosthetic valve endocarditis, separate groups, especially staphylococci, are common. Right. So this will be useful for you. So infective endocarditis, I mentioned earlier, you can divide in the native valve endocarditis and prosthetic valve endocarditis. So native valve endocarditis is from 70% of time streptococci. Especially subacute types are from streptococcal viridans. And intravenous drug users or patients who use intravenous drugs, that is the new term, common pathogen is staphylococcus because it is skin commensal. But for MCQ point of view and also clinical point of view, bowel malignancies can be associated with streptococcal bovis, or Galolyticus is the new name. So if your blood cultures, if your patient's blood culture became positive for these organisms, you have to think whether I am dealing with a patient with bowel malignancy and infective endocarditis. And if patient is having GU disease or tumor or recent procedure, there is a possibility of getting Enterococcus fecalis. If you think the prosthetic valve endocarditis, you can categorize into early and late. Several guidelines says different ways, but I think 2023 guidelines say 1 year, less than 1 year is early and more than 1 year is late. Some guidelines say 6 months. So early endocarditis predominates with staphylococci, Staph epidermidis, and Staph aureus. This is typically due to perioperative contamination or nosocomial pathogens. But problem is they are virulent, more virulent, and have poor prognosis. But late prosthetic valve endocarditis is usual with your usual streptococcal viridans or rarely, less commonly, Staph aureus. I think this is a very common normal slides even medical students should remember. So you might have some idea. In addition to the bacteria, you can have fungi, especially patient who have admitted previous to the hospital and patient is on parenteral nutrition or recent antibiotics or patient use intravenous drugs or patient who are immunosuppressed. So they can have candida and aspergillus. But you will see we do blood cultures, but they are not always positive. Even patient is having infective endocarditis. So if you have negative blood culture in a suspected patient, what are the possibilities? The most common possibility is prior antibiotic therapy. That's why guidelines say if you are thinking of infective endocarditis, you should not give antibiotics without taking all three sets of blood cultures. What are the other possibilities? There are some nutritionally variant streptococci which needs separate culture media or culture methods, or some intracellular bacteria like Coxiella chlamydia, or some fastidious organisms like Hackett group. I mentioned Hackett group down here, Haemophilus, Acidobacillus, Cardiobacterium, Eichenella, and Kingella, likewise Hackett group. So, in other words, some atypical organisms, some specific organisms can make culture negative infective endocarditis. And it can be even non-infectious causes, as I mentioned, Marantic endocarditis and Liebman-Sack endocarditis. So how do we diagnose? I mean, how do we classify infective endocarditis into definite or whatever way? So we use modified Duke criteria. So you can diagnose in 4 categories. Definitive infective endocarditis by using just a pathological criteria, which I'm going to mention. Or definitive infective endocarditis by other criteria. Even though it mentions clinical criteria, it is just not clinical. It may be microbiological or sometimes clinical or other investigation. And it may be definite infective endocarditis or possible infective endocarditis. When if you don't find anything from this category, it is a rejected infective endocarditis. What are the pathological criteria to diagnose definitive infective endocarditis? That is, if you find microorganisms from excised vegetation or abscess specimen, it is definitely infective endocarditis. Or if you find a vegetation or abscess showing active endocarditis, again, that is also from a specimen, that is pathological criteria. So you know it's a definitive infective endocarditis. So this top part is I explained just now. And then other criteria. So to say definite infective endocarditis, you have to have 2 major criteria, 1 major criteria and 3 minor criteria and 5 minor criteria. What are these? And if you want to say possible infective endocarditis, you need 1 major and 1 minor criteria and 3 minor criteria. Don't, I know you can't grasp all these things, even we can't remember all these things, but you have to always look for references. But there are some principles. One thing is rejected endocarditis. What is the rejected endocarditis? In other words, we are not dealing with the patient with infected endocarditis. We are not dealing with patient with infected endocarditis. When your patient has formed a firm alternative diagnosis, which is explaining the symptoms and signs, it is rejected endocarditis. And if you have a patient who clears the symptoms and signs within 4 days, it is very unlikely to be endocarditis, because infective endocarditis cannot be cleared within 4 days of your antibiotic. Some symptoms will improve, but not all. And if there are no pathological or macroscopic evidence at surgery or autopsy, it is rejected. And if you don't meet criteria for possible, at least possible infective endocarditis as above, so it is rejected infective endocarditis. So I'll just explain the major criteria. I told major criteria can be microbiologic criteria or maybe imaging criteria and other criteria. So as mentioned, blood culture is gold standard. You have to take 2 sets. What are the 2 sets? Aerobic cultures and anaerobic cultures. But the problem is in Sri Lanka, most of the time we don't have anaerobic cultures unless you specifically ask for that one, but it is not available most of the time. If your blood culture, 2 or more blood cultures were positive for typical organisms like Streptococcus viridans or Staphylococci like things, it is definitive one major criteria. Or if it is rarely causing, if your organism is very rare one, you need at least 3 separate blood cultures. So few words about blood culture, because you may be the person who is taking blood culture. So it is obtained from the peripheral vein rather than from the central vein, because central vein, there's a risk of contamination and misleading interpretation. You don't take it from the shunt, so even hemodialysis catheter line or something like that. So you have to get the peripheral site with the meticulous sterile technique. You have to clean with alcohol and all these things. You have to do that properly. The other important thing is, for adult, you need usually 10 milliliter of blood, because if you take less amount, it will not grow adequate yield to make it positive. So definitely you have to check with your bottle. Usually it mentions what the amount of blood which is needed. Usually it's 10 milliliter for adult, but small amount for the kids because they have less culture media. So keep at room temperature. If unable to send promptly, you should not refrigerate the culture bottle. But if you suspect fungal culture, you have to discuss with lab and get the culture bottle. And sometimes fungi might work grow in your same bottle. You have to discuss with your microbiologist. Right. I'll just go through. Right. The other major criteria is echocardiography. So as I mentioned, if you have vegetation and other complications, it's a major criteria. Or new valvular regurgitation and or new partial dehiscence of the prosthetic valve. So at least just remember, echocardiography will give some major criteria, some indications, and some evidence of solid evidence of infective endocarditis, and you should uh, be familiar with those indications as well. And from this 2015 and later, people identify sometimes your echo is negative, but still there may be some problem. So then PET scan came into the picture. Because of glucose, it's a substance which is have high activity at the sites of inflammation or infection. So if we use PET with this FDG, the infected area will be showing as very specific area. And if this PET is connected with our CT machine, you can see our normal anatomical structure. So that's why PET CT came into the picture. So it is very good. You can see abnormal metabolic activity in only native and prosthetic valve. I think I have some pictures later, right? So it will give good idea, especially if you have a intracardiac device leads and prosthetic material, and if you find out some embolic phenomenon, something like that. The downside is it can't really differentiate inflammation with infection. But it is a very good technique, but it is not available, widely available. I don't think it is available in Sri Lanka. Uh, but other countries they use, when you have your echo is negative, transthoracic and TOE both negative, but still you are thinking of infective endocarditis, especially if it is prosthetic valve or device related. Then they go with this. There's a surgical major criteria. That means during the surgery, surgeon can say this is infective endocarditis as a definite point. So I mentioned 3 kind of criteria: microbiological, and echocardiographic and other imaging, and surgical major criteria, 3 types. Then minor criteria, if the patient is having predisposition like previous infective endocarditis, prosthetic valve, previous valve repair, likewise, there are things. And if the patient has fever or vascular phenomenon, our evidence of arterial embolization, pulmonary infarcts, cerebral and splenic abscess, myocardic aneurysms, and intracranial hemorrhage. Basically vascular complications. if you find some vascular complication, fever, and evidence of predisposition, you might stack together and say it is likely to be infective endocarditis. So, in addition to that, there are some other minor criteria. Immunological phenomena, positive rheumatoid factor, ocular nodes, blood spots, and other immunological phenomena. And some other microbiological evidence, you don't need to remember these things, which is not categorized earlier. And physical examination, especially here, criteria for new valvular regurgitation. If you identify new valvular regurgitation, not the worsening of changing of pre-existing murmur, it can also consider as minor criteria. So these are some examples of FDG PET CT. You can see some illumination in the infected. This is actually a fontan tube. And this one also, this is a prosthetic aortic valve. You can see some illumination, and so you have to suspect some inflammation or infection going on. If you have to tally with your clinical picture, history examination and other things, you can suspect there is something going on. Very difficult to say whether it's a thing, but if you see this level of collection, it can't be just an vegetation, it can be a abscess. So cardiac CT alone, not the PET CT, you can use cardiac CT, which we do our coronary evaluation as well. It is also useful because it can identify valve morphology, any perforations and complications, and perivalvular complications. And also in prosthetic valves, because if you are an echocardiographer, you might not see very good images in some of the prosthetic valves. So cardiac CT is the one of the good thing to diagnose these things with the complications. I'll give some pictures. This is the aortic valve. The aorta, when it's a root of aorta, and in ascending aorta it comes. Right? So you can see some dark hypodense area. This is a part of a vegetation again, and with some perivalvular abscess. This dark bigger area is actually a abscess. Right? So cardiac CT also helpful in diagnosing. This is a mycotic aneurysm we saw earlier. So once we diagnose, we have to manage the infective endocarditis. How? So we have already done blood cultures and echoes and maybe TOE and other investigations to diagnose. But in addition to that, in our cardiology ward or medical ward or CCU, we do full blood count to identify neutrophil leukocytosis. ESR and CRP is high in bacterial endocarditis. Procalcitonin is high. Blood picture will show left shift of the neutrophils with high WBC. Rheumatoid factor may be positive. Cardiac troponin may be positive if it is really involved with the myopericarditis and other things. BNP can be high if you have heart failure as a complication. Urine full report might show some evidence of renal involvement or glomerulonephritis, creatinine as well. ECG will show if it is aortic valve endocarditis, it can affect perivalvular region, can cause cardiac conduction blocks, heart blocks. And chest radiograph might show some pulmonary complications and evidence of heart failure. So a lot of things. In addition to that, you can go for some other things like colonoscopy. If you are thinking of Enterococcus faecalis or Streptococcus bovis, you are looking for source of this bacteremia or any evidence of neoplasm. So you might have to do the colonoscopy for this patient once they settle to tolerate this. And then if you are suspecting some cranial problems, you do brain MRI. And serological and molecular testing are available even in Sri Lanka. So if you suspected cases of culture negative endocarditis, I didn't go through that because there are a lot of charts, series for different suspected pathogens, some PCR, ELISA test, and all these things. You can follow that. So sometimes you can get, if cardiac surgery is done, you can get some histological samples for things, but it is not routinely cultured. But if surgeon thinks this is likely to be infective endocarditis, he can also send it to culture. As I mentioned, cardiac CT, I already mentioned these three, cardiac CT and cardiac PET CT. So what is the treatment? So mainly it's antimicrobial therapy. That is the medical part. So few principles. You have to give, this is after blood culture, and you have to use bactericidal doses of bactericidal antibiotics. And so it is therefore most of the time you are starting with IV intravenous, because it ensures the bioavailability. So it is a prolonged course. So it may be 4 weeks or 6 weeks, and some exceptional circumstances, new guidelines says shorter duration for uncomplicated infective endocarditis such as streptococcal viridans, uncomplicated infective endocarditis with very good resolution. You might try shorter duration according to new guideline in the patients who can be followed up. So this guideline says to perform TOE before, because so in this one, usually they say initial period up to maybe first 2 weeks, early critical phase. Then it's a continuation phase. So we give maybe combination of antibiotics. In this early critical phase, gentamicin we commonly give for 2 weeks. That is the early critical phase. And then by the time of the latter part of the second week, you can do TOE to see whether your gentamicin or second antibiotic is okay or any complications. You can perform the TOE. Some more principle. So if if needed, combination of bactericidal antibiotics are preferred, combinations of it, not a single antibiotics. And definitely longer duration or 6 weeks or more is recommended for prosthetic valve endocarditis, because prosthetic valve endocarditis are more problematic, more complicated, and very difficult to eradicate and may need the surgery as well. And due to do a clearance blood culture after second, third day if the initial blood culture is positive. This is very important, because if your blood cultures are initially positive, just wait and see for another until end of the critical phase, so maybe even full time. What you have to do is after 48 to 72 hours, second to third day, you have to get another culture, see whether your initial treatment is working now. So one of the drugs I just mentioned, aminoglycosides. It's a synergized cellular beta lactams for bactericidal activity. So giving aminoglycosides like gentamicin reduces the total duration of the antibiotics, and you can use single daily dose. So I just mentioned, I quickly go through some, you don't need to remember, but common things you should already aware. Common types, common combinations of antibiotics we use in our day-to-day practice. If you have initial empirical treatment, because that means you have a patient suspected of a native valve endocarditis, and you don't know which bug is there, so you can start with your ceftriaxone and gentamicin, or maybe ampicillin with ceftriaxone. Likewise, if it's a prosthetic valve, vancomycin with gentamicin or rifampicin. If it's allergic, you can go with vancomycin with gentamicin again, even in native valves. You don't need to remember all these things, but you should be familiar at least some of the things as you are working in the same this important environment. So there are in guidelines you can go through, but basically we can start and we always get the microbiologist opinion about the progress and antibiotics, because they will guide to particular, because initially we start with empirical antibiotics. Sometimes we might narrow down the antibiotic once you get the direct culprit with the blood cultures. So I'll just go through because you don't need to remember all these things. The special some special organisms, Brucella, you need doxycycline, cotrim, rifampicin combination, something like that, for longer duration, 3 to 6 months. So depending on the culture and complication, organism and complication, you might have to give prolonged course. So this is very difficult. Sometimes you have to give peripheral lines, and sometimes you might even have to start central lines to give. You have to convince the patient feel that I am better, I have to go. So it's a part of our professional duty to educate the patient and keep the patient for that adequate period. In common situation, it may be at least 4 weeks or maybe even 6 weeks. It's very difficult to keep the patient, but other countries they have outpatient intravenous antibiotic therapy programs. To twice daily they can visit nearby place with antibiotics and get the things. So I'll just go through. So that was medical management, but it will not suffice or uh, enough in some situation. I'll just summarize the things in the very crowded slide which was taken from the Mayo Clinic course. I borrowed actually with the, I think it's from the Jack, Professor Nishimura's. So which patient need to go to the operating room? So if your patient got valve dysfunction, say severe mitral regurgitation with heart failure due to infective endocarditis, it's an indication for surgical treatment. In fact, I'll in next slides I'll say the what is that real timing, but this may be a very emergency case. Emergency case. So in addition to that, if the patient is in heart blocks, abscesses, or very destructive lesions like some fistulae, you have to go for surgery. And left-sided Staph aureus or fungal organisms also indication for surgery, and persistent bacteremia or fever more than 5 days. That means you are checked blood cultures you are doing at the third day or later, still positive, and you ideally this patient should go for surgical treatment. Right? That means they will go through and find out the vegetation, and they might remove or replace the valve if it is a valve. And recurrent embolization or persistent vegetation despite antibiotics is also indication. And if the vegetation is really large, because large means larger burden of bacteria and higher chance of to be embolized. So it is also indication, but the level of the level of evidence and the recommendation is low. It's a 2B indication. So if the patient is having other indication for surgery and recent stroke without hemorrhagic or extensive damage, so you again do the surgery. Always, I mentioned, it's a teamwork. You have to get the cardiothoracic surgeons on board. They are really busy people, so you have to plan it out. When to refer? Obviously, as early as possible if you think patient needs surgery. Emergent surgery means surgery within performed within 24 hours, urgent within few days, elective 1 to 2 weeks of antibiotic therapy. So you have to do emergency surgery if the patient has cardiogenic shock due to progressive native or prosthetic valve obstruction or fistula formation. It's an emergency surgery. You have to do surgery same day. But if you have a patient, you can buy time. It may be progressive heart failure with which is not very responding to the thing and now becoming hypotensive. You can discuss earlier the better. But you can get something because it takes some time to act your antibiotics, but within 1 week you have to do. Likewise, surgeons, microbiologists, as a cardiac anesthetic, we have to get together and decide where we intervene, right? So depending on that, emergency surgery, urgent surgery, or elective surgery uh, will be decided. So I'm not going to do the same thing. So one word about the anticoagulation. If the patient is having neurological complications such as stroke, it is mostly like septic embolism or maybe myocardial aneurysm rupture. Whatever it is, ischemia happened. And the problem with this infective endocarditis is there's a very high chance of hemorrhagic transformation, and it worsens the stroke, right? So therefore, it is recommended to avoid this hemorrhagic transformation, to minimize the hemorrhagic transformation. If the patient is having cerebral embolism or stroke, you have to stop anticoagulation. That means you have to stop warfarin despite the indication. It may be prosthetic mitral valve, but you have to stop warfarin. But always you are not going to stop, you have to discuss with your cardiologist. But this is one of the evidence-based recommendation. And you are not going to start aspirin or other antiplatelet agent as adjunctive therapy in infected endocarditis, right? So, because this is the dreaded complications, despite whatever the indication, it is recommended to stop warfarin. Right. So we are having the latter 1/3 of the lecture. We have to follow up this patient. Once, say, you have done your medical treatment and it is enough, and now patient is happy to go after your thing. So before discharge, you have to do a transthoracic echo and reassess the situation at the end of the antibiotic course. And patient, in a complicated case, maybe patient has had cardiac surgery and valve replacement or something like that. So most complications occur within the first 12 months. So vigilant follow-up should be considered by your IE team member. 3 months, 6 months, or 12 months. Because one thing is complication, the other thing is the recurrence. It's a minute one, it's a 2 to 60%, but as I mentioned earlier, the highest risk factor for infective endocarditis is previous infective endocarditis. And also, up to 30% of patients may require surgery within the first year because of your residual damage to valves or some other structures. So patient education is important. I'm going to discuss the latter part. All right. So the last part is prevention of infective endocarditis. So two ways: you have general measures or infective endocarditis prophylaxis with antibiotics. What are these? I'll first go with the antibiotic prophylaxis. You have to decide which patient needs antibiotic prophylaxis, which procedure needs antibiotic prophylaxis, the drugs we are going to use as prophylaxis. Right. So antibiotic prophylaxis needed for patients or populations at highest risk of infective endocarditis. That means these patients are needed infective endocarditis in the appropriate setting. So what is that? If the patient has previous infective endocarditis, or patient with surgical implanted prosthetic valves like TAVR or mitra clip, or some cardiac valve repair material like annuloplasty rings, something like the surgical implanted prosthetic parts, then they are high risk. This patient, you have to think of giving antibiotic prophylaxis before some procedures we are going to discuss. Or patient with ventricular assist device, it may be left ventricular commonly. Or patient with heart transplants, especially with valvular disease. There are more. If the patient is having congenital heart disease and which is cyanotic heart disease, which is unrepaired. So for example, if you have a transposition of great arteries, which is not corrected, so that patient is high risk. Or patient has cyanotic lesions with palliative shunts and conduits. That means they had surgery, but they are palliative shunts. So those patients needs infective endocarditis prophylaxis. Or you have repaired any congenital heart surgery during last 6 months with some prosthetic material. For example, ostium secundum ASD with ASD device closure within last 6 months, or PDA device closure, or maybe VSD device closure. Then within that particular 6 months, we think that endothelialization of the uh, uh, prosthetic material has not happened properly. So it is recommended to give infective endocarditis prophylaxis. Or any repaired lesion of any congenital heart disease with residual defects, then it can have more powerful shunts and high risk. Then who does not need prophylaxis? Acquired valvular heart disease like acquired calcific aortic stenosis, mitral regurgitation, or even MVP with thickened leaflet or MR. According to the current context, I mean, a new recommendation over last 15 years, they say you should not give infective endocarditis prophylaxis for MVP with MR. But sometimes, even myself, I think even Dr. Guruparan will agree, sometimes we feel it is torrential to get that bold decision we might give in some aspects with the MVP with very significant MR. But according to the European guidelines, they say you don't need prophylaxis. So we might sometimes individually decide to give things, but guidelines say no. The prior rheumatic fever, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is actually not very low risk, it's a moderate risk. But generally, you should not give antibiotic prophylaxis. Or, as I mentioned, uncorrected ASDs, VSDs, bicuspid aortic valves, coarctation aorta, that these are non-cyanotic lesions actually. Uncorrected non-cyanotic lesions will not need antibiotic prophylaxis. So it should be considered in high risk patients, not recommended for patients with low or moderate risk of infective endocarditis. But sometimes moderate risk patients, we will decide then and there according to our things, because in our areas, I mean in Asia, we don't have much details at the moment, but still I think we have to stick to the European and American guidelines. It will work. So procedures. Actually, the slide inadvertently came earlier, but I'll go to the other ones and then come back. So now we identify the patients with some lesions, and then what are the procedures we have to think? Especially high risk dental procedures, because our viridans and many of our culprit organisms are in the near the teeth. So if a patient is going for dental extraction, you have to give oral surgery procedures like periodontal surgery, implant surgery, oral biopsies, or any dental procedures involving manipulation of gingival or periapical region of the teeth, including scaling and root canal procedures, needs uh, infective endocarditis prophylaxis, especially patients if the patient is having in high risk category. Non-dental procedures. Actually, some early guidelines say many of the non-dental procedures need any infective endocarditis prophylaxis, but nowadays they say more liberal. You have to decide, but especially there are some guidance still. If the patient, if you are, what are the non-dental procedures? If you are having active infection, soft tissue infection or skin infection, if you are going to put scalpel to that, or debridement, wound debridement, then consider this. Or musculoskeletal structure with infection, abscess drainage, then you have to give prophylaxis. And incision or biopsy in the respiratory tract, like tonsillectomy, adenectomy, bronchoscopy with biopsy, then you have to give antibiotic prophylaxis. So which procedures don't need prophylaxis? Just dental X-ray injections, so X-rays don't need. Placement of or adjustment of orthodontic appliances, just adjustment of your brace, uh, dental braces. Or bleeding or trauma to lips or oral mucosa. If it is a minor trauma, you don't need. Or shedding of deciduous teeth. Or bronchoscopy without biopsy. Or GU and GI procedures without active infection. If you think you are going very less infected or sterile procedure, then you don't need to give. Even for urethroskopy or endoscopy, or you don't need to give. So this is a different slide. As you are working in the cardiology ward, you should know what are the procedures which needs prophylaxis, infected cardiac procedures. If your patient is going for surgical prosthetic valve implantation, that means aortic valve replacement, mitral valve replacement, something like that, definitely you need infected cardiac prophylaxis. This is a class 1 recommendation, right? If your patient is now going your new unit started TAVI procedure, still yes. Or mid-trachelic, yes. Or if your surgeon is going to do intravascular prosthetic material like aortic graft, yes, you have to give. Or your cardiac electrophysiology team wanted to do a pacemaker, ICD or CRT, yes, it is recommended. In addition to the aseptic and sterile technique, right? Any other foreign material, annuloplasty in code, that's again surgical. Yes, that means many cardiothoracic surgeries and many interventions still need. But for cath lab, coronary angiogram, you don't need. PCI, you don't need. Just electrophysiology studies without any device implantation, you don't need. Or diagnostic catheterization like right heart catheterization, you don't need. PTMC, pulmonary valvuloplasty, you don't need. But then and there, sometimes you might give depending on the patient's situation, but generally it is not needed. Coronary artery bypass graft, yes, because this is actually not because of the infective endocarditis, just as a standard perioperative prophylaxis. So what are the antibiotics? Now I mentioned what are the high risk conditions and what are the procedures, what are the antibiotics you can use. Actually, they only mention for the dental prophylaxis, that which covers the viridans streptococcus, right? So common antibiotic is amoxicillin 2 grams orally, single dose, 30 to 60 minutes before the procedure. That is the usual common drug we use. If the patient is allergic, you can go for azithromycin or clarithromycin 500 or doxycycline 100, same time. Some guidelines previously clindamycin recommended. Clindamycin may not be recommended in this, it was not recommended from this guideline because some people have some concerns about the Clostridium difficile increase because of the even single dose. So that's why ESC guideline recommends azithromycin, clarithromycin, doxycycline as the for the patient with allergy to penicillin or ampicillin. So in this left side, for non-dental procedures like GU procedures, GI, respiratory or skin procedures, as I mentioned, they didn't want to give routine IE prophylaxis because there are no clear evidence. But even in high-risk patients, but if you think we are dealing with if the operator thinks we are dealing with the infected area, say for example you have an infected urinary tract with some pyonephrosis or something like that, then it's better to give antibiotic. But then you are not going to do amoxicillin for that. You have to target that particular infection at that particular site. It may be E. coli coverage, something like that, because you have to reduce the active infection and reduce the bacteremia. Right. So I mentioned the antibiotic prophylaxis. So prevention, there are two arms I mentioned. One is antibiotic prophylaxis. Second arm is general advice. So this is very important. This is the part I wanted to tell at the discharge of your patient, or even for your high risk patient before getting the infective endocarditis. What are these? Advise him to maintain good dental hygiene. Use dental floss. You have to brush teeth morning and evening. Even some uh, people say it is the most effective way of reducing infective endocarditis. Brush twice a day, and you encourage those patients to see their dentist for regular checkups. So dental hygiene is the utmost important thing for these patients. You have to tell this when the patient is discharged, or even high risk patients even before this. Maintain good skin hygiene. So they have to ask advice to have undue skin wounds and other things. If you get a wound or any evidence of infection, like even cellulitis, you have to tell these are the features of infection and treat appropriately. And high risk patients should uh, be avoiding tattoos and piercing. They have to ask not to do that, those things. Right? So those patients also should aware about any infections, for example, especially fever and some generalized symptoms. Then we have to advise not to uh, wait, see their doctor, maybe even general physician, and tell that I have these problems, and one of the differential diagnosis is infective endocarditis. And do not self-prescribe antibiotics, because it can cause resistance, and even blood culture will be negative at the outset, right? And also, if they are having high risk, they should take the diagnosis they already have before they consult any doctor. So prognosis. What is the prognosis? So in hospital mortality is around 15 to 20%. 1 year mortality is around 40%. Left-sided infective endocarditis has higher mortality rate than right-sided. Fortunately, our commonest type, viridans and native valve endocarditis, have better prognosis. Obviously, higher mortality is associated with several factors. One is, I already mentioned all these things. When you have more virulent organisms like staph, if you have complications such as heart failure, pulmonary edema, or extended infection with paravalvular involvement, uh, and complications. In addition to that, mitral valve vegetation has higher mortality, and prosthetic valve endocarditis has higher mortality. And if patient is already having comorbidities, diabetic, hypertension, and even older age, it is common sense they have higher in hospital mortality with infective endocarditis. Few words about the CIED, cardiac implantable electronic devices, right? So pacemakers, ICD, CRTs, such as. So nowadays, there are a lot of patients are with these, and so you can have CIED infective endocarditis. So incident is increasing. So percutaneous device erosion or purulent drainage is present at the pocket site. You might see infection at the pocket site, erythema and some swelling, and they complain some pain. And these are usually at the right side of the hearts, these leads. If the leads are infected, you can have pulmonary manifestation, pleuritic pain, lung infiltrates, lung abscess, even empyema. So this patient, in addition to that, have our usual stigmata of infective endocarditis, cardiac and peripheral stigmata. How do we manage? The problem is they are infected with more virulent organisms, staph. In other gram-positive cocci also can be possible. The management is, as usual, blood cultures, echo. But here, as I mentioned, TO is very much important, and PET-CT is also very important. And IV antibiotics we give, which is covered in staphylococci, and more importantly, now many of the guidelines say as class 1 indication, you have to completely remove the device. And once it is settled, you have to reimplant. This is the very painful situation for us as well, in addition to the patient, because retrieving this kind of thing is also difficult, and implanting a new one is also difficult. So, but the guidelines say it is very, otherwise it's very resistant to outlook, for the better outlook. So these are my references: ESC guidelines, Brownwald and Mayo Clinic, and there are a lot. So I think if you have any questions, I can answer now. And I have two questions. Dr. Guruparan, shall I ask those questions, or you want to